peds, and this will be the second part of pediatrics. And here's what we're going to talk about. Things we can talk about. We'll look at common things. We'll look at some neurologic issues in children, and it's usually male-related. I have good news for you with regard to congenital heart disease because we need to pay the comparison we know for the adults. Before you can get a hip, I know about that. Infectious diseases, those viral symptoms. Remember when you're taking the exam, they all tell you. Amalia had a boatload of pediatric rashes. Infectious diseases, I made 2 charts for you that'll really cut to the chase. So we'll do that. And then we're going to end with one ENT problem we haven't talked about yet. What is it? Otitis. All right? So here we go. Let's start out with something called hyperbilirubinemia. It means the bilirubin level elevated. How elevated? Well, an infant who is 35 weeks old or older, they're in the 95th greater percentile for bilirubin levels. And that's a problem. It's a problem because bilirubin is toxic to brain tissue, and that's where bilirubin is deposited. We have a special name for it. It's called bilirubin-induced neurologic dysfunction, and the acronym is BIND, right? Like you're in a real bind. So let's talk about bilirubin. You remember 2 days ago, I kind of made a joke to wake up. I said, hey girl, where do you keep bilirubin? The main repository of bilirubin is in your red cells. So it's so stressful that you're born, a number of red blood cells hemolyze, meaning they explode. When they explode, bilirubin. Now, when we talk about bilirubin, you know I told you how the liver grabs it, conjugates it, and uses it, recycles it? Well, a newborn's liver is usually very immature. And if the newborn's immature liver is too immature to clean up all those red cells that have spilled bilirubin, then bilirubin level rises. And we got to monitor bilirubin levels in newborns because we know that those levels are going to escalate. Look at my question. An infant has physiologic hyperbilirubinemia. Most people in this room had it. It usually appears when? It usually appears about 2 to 3 days after birth. The other thing you should know is that any time hyperbilirubinemia appears within 24 hours of birth, flags go up, because that's a big problem. But most of us in this room have physiologic hyperbilirubinemia. So when is the little peak? When do I have to stop worrying about it? Well, in full term, it's about the 3rd or 4th day. In preemie, it takes a little bit longer. Usually by the end of the first week of life in a preemie, the bilirubin level has top that's not getting high. But take away this anytime jaundice, which can be evidenced by hyperbilirubinemia. With the first 24 hours, huge red flag. So how do we know how much is much? Well, you might look at the lab value, but we have this thing, the lab value comes from this called bilirubinogram. So it's line down here, 24, 48 hours, 72. And this is expected value. So it's also good. It just kind of lets us know where that infant's bilirubin level is and when we should get to be worried. So here's your patient. A 4-day-old term infant who is dead has bilirubemia. It's 18. Okay, stop. Look at your nomogram. If they're 4 days old, that's 96 hours. And if it's 18, it's right here. You see it? Okay, so it's high. The question says, how do you treat that? And while we don't want to stop breastfeeding and we want to keep them well hydrated, it's treated with number 2, which is what? Phototherapy, exactly, circle it. So, look at this, because I'm changing gears. I'm still in the GI tract, though. At what age are symptoms of colic most likely to occur? Let's see, how about 4 to 6 weeks, right? That's when we first begin to see colic occur. When does it go away? By about 3 months, right? So 1 to 3 months can be pretty trying, especially for new parents. Well, look at this one. A 2-month-old comes in to be examined by you, and she's got an ankle bracelet made of tiny flowers. The baby's mother states that this prevents colic. How should you respond? Well, number 1 says leave it on. I'm okay with that, but it says encourage its use. Okay, no. Tell the mother it's not going to help, just take it off. No. You should recognize number 3. Recognize that it's a harmless cultural practice. Don't discourage or encourage, but this whole thing goes to encouraging people to be engaged in own cultural practices. Well, look at this baby. A 6-week-old infant has visible peristaltic waves. Okay, what's that? Visible peristaltic waves in the upper abdomen, just before the baby vomits. I don't know what that is, but it's important, right? What is likely to be included in your differential? Pyloric stenosis, exactly. Circle number 4, and let's talk about pyloric stenosis. When you have pyloric stenosis, you know what you really have? A stopped-up drain. Let me show you what happens with pyloric stenosis. Right here is a hypertrophied pyloric muscle. Fluid will come down the esophagus into the stomach, and it has to clear through that pyloric area. As long as there's place for fluid, like milk, that's in the stomach, goes through that area, everything is okay. But at some point, more milk comes in than can get through that narrow passageway. And so what happens? They have projectile vomiting, right? So they have vomiting that occurs. So at what age are symptoms of pyloric stenosis most likely to occur? When do they start having that? 3 to 6 weeks, right? Circle number 1. So think about the significance of that. You have a little month-old infant who's having projectile vomiting. Do you realize that prevention of dehydration has become at the top of your list? They can become dehydrated rapidly. And so here's how they present it. For whatever reason, it often happens in first-born males. I don't know why. It's one of those things you observe in practice. It typically happens after they eat because the stomach fills, milk can't get through that stenotic area, and after a vomiting episode, you can sometimes palpate in the right upper quadrant this kind of, I would only describe it as a knot. And what you're palpating is that hypertrophied pylorus. So this is a favorite one to see on exam questions. They like pyloric stenosis, not because you're going to see a lot of it, but because you need to be able to recognize it when it occurs. So here's your next patient. A 4-week-old has suspected pyloric stenosis. They're the right age. What imaging study is most commonly used to diagnose this? How do you diagnose it? With an ultrasound, right? Because you want to look for soft tissue, and that's exactly what that hypertrophied pylorus is. So an ultrasound, circle number 3. Your job is going to be to punt. You got to get this baby in, usually to an ER where they can get some fluids in them. And then either PD surgery or whoever in your area does that procedure comes in, usually get them well hydrated and do it at the earliest convenience, like this evening or tomorrow morning. And they usually do really fine. All right, they go home and they do great. In the GI tract, there might be the most common thing you'll see in a regular primary pediatric practice, and that probably is going to be reflux. And so here's what you have to know about reflux. In infants, just like in every one of us, you have spontaneous opening and closing of the LES. In adults, as I told you, it happens commonly after you eat. But in little infants, especially under a year of age, that spontaneous opening and closing happens multiple times in an hour because their little LES hasn't matured yet. So we see a lot of reflux in infants, and it's completely normal. It's due to immaturity of the LES. When it's pathological, we call it GERD, just like we do in adults. Now, when a baby is brought in to you by a caregiver who says, my baby spits, I'm afraid they have that GERD thing. They spit up every time I feed them, they spit up. I don't even know if they get enough food. There are 2 things that really have to drive your history with them. The first one is there any pathology going on? Like, do they have GERD? Do they have something keeping fluids from going down? And the second thing is, if this is reflux, are there any complications because of it? Because you know it's a normal event. They reflux up to 30 times in a day. It just happens over and over again. So is there a problem is the other thing that's going to drive your discussion. With regard to history, what you're always looking for are red flags. For example, if the caregiver reports choking or coughing with eating, I'm thinking about GERD. If they report something like forceful vomiting, what you thinking of? Maybe pyloric stenosis, exactly. Blood in the stool, I don't know what you have, but I don't think it's good. Maybe I'm thinking about intussusception. And then if you have any kind of symptoms in the lower GI tract, oh no, something is up. Because GERD does not involve the lower GI tract. And then finally, if you're running fever, I for sure am not thinking GERD in you. So the first thing you're going to do is get a really good history from it, and you're looking for red flags. The second thing, as I told you, is you're looking for anything that seems like because of these symptoms, it's producing complications. So for most reflux, that infants are going to be brought in to see you with, there are usually no interventions. You need to do some teaching and reassurance to the caregiver that they have this. It's because of immaturity of the LES. There's some things you can have them do, and I really don't know why, but cigarette smoke does expose you to, does all kinds of things to babies. It increases their risk of otitis media, but one thing it does is it increases their risk of reflux. So if somebody in a household smokes, we want to make sure that they smoke outside, not hold the baby right after they smoked. You know all those interventions. The other thing that you could have them do if they just have to do something is use small, frequent, thickened feedings. That seems to help a little bit. What you see providers do all the time in clinical practice is they change, and I suppose you could try it, but to be honest with you, it doesn't seem to help that much, or usually does not help. If you want to switch the formula to like a hypoallergenic one, please be cognizant of the fact that try it for a week or two and see if it helps. If it helps, have at it. But if you switch them to a more expensive formula and it hasn't improved symptoms, then don't keep them on that formula. I look at poor families who come in and I see these expensive bottles of formula. And I'm thinking, that's $30, that's $60. You can have a steak at Ruth's Chris for that amount of money. You got to think about the cost of interventions and certainly compliance with things that are that expensive. So keep that in mind. Now, really important. Suppose you decide, this baby does have pathologic reflux. Yes, I think I can handle it. No, I don't think I need to send them to PDGI right now. Here's what AAP, American Academy of Pediatrics, says you should do. If you're going to try them on a medication, don't use an H2 blocker. The preference is a PPI, proton pump inhibitor. And here's what AAP wants you to do. Start them on a PPI and bring them back in 2 weeks. In 2 weeks, if they're not better, consider sending them to PDGI. If they are better in 2 weeks, and they ought to be if you got the right diagnosis, then keep them on it for 2 more months. And then make sure you bring them back. What you never want to do with an infant is put them on a PPI and leave them on a PPI like we do with those old adults. And here's why. When you take a PPI, whether you're an infant or an adult, it inhibits your ability to absorb, just listen, calcium, vitamin D, iron, B12. Wow. This little infant is in a period of rapid growth. They got to have those. They've got it. We put those things on board when it's little, it's a rapid period of growth. Consequently, AAP is all over. Providers who put patients on PPI and just leave them on it. Now, last point, and it's this one. You remember I told you what drives this? It's an immature LES. That LES ought to be matured by about 9 to 12 months of age, at which time you should go pull them off that PPI. And if you can't, then you need to think about sending that patient over to PDGI. All right, so you got it? So take home message, don't put a kid on a PPI and leave them on it.